area of prostate cancer therapy, particularly around ideas for combination therapy, ideas around immune-based therapy, as well as using the genetics and the genomics to guide therapy. So the two talks today will focus on this idea of combination-based therapy and then also immunotherapy, and then the tumor board that I alluded to will sit and talk about a couple different cases. We'll kind of bring in some of the genetics and genomics piece as well. So our first speaker here is Dr. Mike Schweizer, who's an assistant professor at the University of Washington with a practice both at UW and the Cancer Care Alliance. And he's, for many of you may know, he's really pioneered the idea of giving high-dose testosterone, kind of a counterintuitive approach for advanced prostate cancer, and he's going to give us the landscape of the combination treatments. Mike?
All right, thanks, Pete. So I'm going to talk a little bit about combination therapy to treat prostate cancer, and I just wanted to start by going over some basic prostate cancer biology and sort of outline sort of the general approach that we use for treating prostate cancer, just to give us a sort of background to move forward. So this is sort of a crude schematic showing the androgen receptor signaling pathway. This is the main pathway that drives prostate cancer growth, and the way that it basically works is that if you imagine in circulation, you've got androgens. The most sort of commonly recognized one is testosterone. These androgens can drive the cancer to grow by essentially migrating into the cancer cell where it binds to the androgen receptor. And then this complex can move into the nucleus, attached to the DNA of the cancer cell, and this can set off a cascade of events that can drive the cancers to grow and spread and do bad things. And so when we think about treating prostate cancer, the sort of main way that we've done this over the past 7 or more decades is really by trying to prevent this process from happening. The most sort of common way that we do this is with drugs like Lupron, androgen deprivation therapy. It decreases the amount of androgens in circulation, so you're basically starving the cells. Newer drugs like Zytiga can decrease these androgens even more, so you more effectively starve the cells. And then drugs like enzalutamide or now apalutamide are able to basically block androgens from binding to the receptor. So basically the idea is the same with any of these drugs, is you're preventing this signaling pathway from driving growth. But the real problem is that even though we are able to shut this pathway down very well, we still develop resistance and cancer still progress after any of these drugs. Another way to sort of think about prostate cancer treatment is sort of longitudinally, how it occurs from the beginning to the end of the treatment cycle. For most patients, when they present, they have usually localized cancer, so it's still in the prostate, it hasn't spread. At this point, they will hopefully go for a curative therapy like a prostatectomy or radiation therapy, and that results in the tumor volume decreasing. The PSA should hopefully go to 0. Some of those men, most of those men are probably cured. At some point, though, many patients relapse, and you see the PSA go up, the tumors increase, and this is the point when they've got an incurable cancer now, and we think about using medication to try to control it. This is when we use drugs like Lupron and other forms of androgen deprivation therapy. We also, more recently, in the past couple of years, started using chemotherapy and drugs like abiraterone in this setting because they've been shown to be more effective when you use them earlier. This is going to result in cancer control for a variable period of time, but when things progress, we say they have castration-resistant prostate cancer. And this is when we think about using one of 7 drugs, and basically we cycle through these drugs one after the other after the other. The standard of care in 2018 isn't to use these in combination, but to sort of sequence them sequentially throughout the course of somebody's treatment course. And usually this is going to result in PSA dropping transiently, although resistance will develop and it rises. It'll drop again with the next drug, but eventually at some point we're not able to control it anymore in spite of all these good drugs. And so the concept that I wanted to talk about was that perhaps through combination treatment strategies, we can develop a more effective way to treat prostate cancer. Instead of using drugs sequentially, maybe using them all at once would be a more effective way to treat the cancer and keep it under control. And I think this is sort of proof of concept of that. These are 2 figures from 2 separate papers that led to the use of either abiraterone or Zytiga or chemotherapy in men that have newly diagnosed prostate cancer. Prior to these papers coming out, the standard was to just use drugs like Lupron alone, but these studies show that when you combine Lupron with either of these drugs, you result in controlling the cancer better for longer and men live longer. And these curves basically just show that if you get abiraterone, the rate that men die of cancer goes down. You have better survival with that drug. The same is true if you use docetaxel chemo. And so this is kind of proof of concept that when you combine therapies together, you can get better control of the cancer and results in better outcomes. And so I wanted to talk about a few examples of combination studies that we have either going on now or planning to open. And so I kind of broke this down into sort of crude categories, which just gives us a way to sort of conceptualize what we're working on here. The first is what I call sort of the brute force method. This is where you take multiple drugs that we know by themselves work and test whether using them in combination works better. The next is looking at really developing a strategy where you use a second drug to try to combat a resistance pathway or another pathway that might be an alternative way to drive the cancer growth. And the last one is looking at what I call rational combination. So understanding the biology of how a treatment works and then selecting another drug to try to help the first drug work better. And so the first example I'll give you is of one of these brute force strategies. And so this is basically a study we're doing looking at using multiple drugs that inhibit androgen receptor signaling to try to have better outcomes in men planning to undergo surgery. And just for some historical context, there have been a number of studies in the past that have looked at using hormonal treatments in patients that were planning to get surgery. This was, these older studies typically used drugs like Lupron just by themselves. And in general, the outcomes were not really that impressive. There was no impact on long-term survival or long-term control of the cancer. And overall, when you looked at the prostates from patients that got, say, Lupron before surgery, only around 5% or so had a complete response, meaning no cancer that they could detect in the specimen. They've done a couple of more contemporary studies where they've maybe combined Lupron with one of the newer drugs, like abiraterone, and they've seen that you can increase the complete response rate up to about 10%. Still too early to know if that has any meaningful impact on long-term outcomes, however. And so what we wanted to do is take sort of the next step and try to not just combine Lupron with one drug, but basically throw the kitchen sink at it. So this is a complex figure, but it's basically outlining all the different sources of androgens that a man's body can make. The primary one is through the testes, and the secondary sources are from like the adrenal glands, and the cancer itself actually learns how to make testosterone at later stages. And so the idea is we want to try to prevent androgens, no matter where they come from being available to drive cancer growth. And so this study combines the drug Degarelix, which is like a newer Lupron, to prevent the testes from making androgens. It uses abiraterone or Zytiga to prevent the adrenal glands from making androgens. And it also uses apalutamide to block any androgens that might be left over from binding to the receptor. And then last, we use a drug indomethacin as well as abiraterone to prevent the tumors themselves from making androgens. So it's basically just coming at it from every angle to stop androgens, stop testosterone from being available to drive the cancer's growth. And this is just the basic outline of how the study works. If you have high-risk prostate cancer, which would be a Gleason score of 8 or higher, PSA over 20, or a high tumor stage, then you can enroll in the study, get all 4 of these drugs for 3 months, and then at the end of this, you get a surgery. And the hope is that we're going to see minimal cancer left over in the prostate, and that in the long run, men do better. The next strategy I want to talk about is sort of this idea of targeting resistance pathways or alternative pathways that can drive cancer growth. And so again, this is sort of our androgen receptor signaling pathway that we talked about. And so again, we've got lots of drugs that can stop this pathway from working. But the problem is when you do this for a long, long period of time, the cancer cell learns how to grow in spite of this. And one of the ways it does that is by learning how to rely on other pathways that can drive the cancer growth. And so when these other pathways fill in, then this can keep the cancer alive and cause it to spread, even though we've already shut down this pathway. And so in theory, if we had a second drug that could turn this pathway off, you would imagine that the combination of the 2 drugs would be more effective at keeping things under control. And so this is a schematic for a study which we are designing and hope to have open in 2018, where we're trying to do just that. So men with castrate-resistant prostate cancer are eligible to enroll if they've already progressed on both abiraterone and enzalutamide. So these are patients that their cancer's really learned how to become resistant to our best drugs at stopping androgen receptor signaling. When you enroll, the patient basically stays on the drug they were most recently on, and we add another drug that stops one of those sort of alternative resistance pathways. In this case, it's a drug that inhibits the FGFR pathway, since we know that's one of the key pathways involved in driving growth at this stage. This is a study that, again, will hopefully open in the next few months. It's partially funded through the IPCR, and I think we're all very excited to see how this pans out. The last one I wanted to talk about was the idea of developing rational combinations. And so the idea with this is that if you understand how a drug works, how it actually kills the cancer cell, then you can come up with strategies that might enhance that drug's efficacy. And so I'll give you an example of something I've been working on using high-dose testosterone to treat prostate cancer. And so the idea behind this is that when prostate cancer cells adapt to a low testosterone environment over many years, there's a number of events that happen that can essentially make them sort of comfortable in that low testosterone environment. And so when you take those cells that have grown, that have adapted to this low testosterone environment, and you expose them to really high androgen levels, high doses of testosterone, you can actually kill cancer cells. And one of the ways that we know this happens is that exposing these cells to high-dose testosterone or other androgens can actually cause DNA damage. And so this is a figure from a paper we put out a few years back where we essentially used a stain that lights up pink whenever you see evidence of DNA damage. And so here's the control cell. These are cells that are happily growing in media that don't have any androgens aren't being treated with any androgens at all. Over here, this is treating the cells with DHT, which is another sort of more potent form of testosterone. And you can see that there's a lot more of these pink dots indicating that it's causing DNA damage. Likewise, the chemo drug Etoposide also causes DNA damage, but when you combine the two together, you see more DNA damage still. And this figure basically just shows that when you add androgens, you get DNA damage. There's more with Etoposide, and there's the most with the combination. And so when we sort of thought about translating this concept into the clinic a few years back, we developed a form of therapy that we called bipolar androgen therapy. The idea is that you're going to treat men with cyclic doses of high doses of testosterone, which results in the testosterone levels spiking sky high, falling over the next 30 days. Another dose sends it up again, and you sort of ping pong back and forth. The idea is that you're staying one step ahead of the resistance so that the cancer cells never get too comfortable in either a high or a low androgen environment. It also probably exposes the cells to sort of repeated cycles of DNA damage. And so we tested this concept in the clinic. And in our first study, we actually combined testosterone with that same chemo drug, Etoposide. And the way it worked is we give men 3 months of the combination therapy, and if they were responding favorably, they got to go on just testosterone alone. And this slide basically outlines the general results. So this figure here basically plots each patient who was enrolled is a single bar, and the bars that go up indicate that their PSA rose on study, and the bars that go down indicates that the PSA declined. And you can see that about half the patients had PSA declines, and 4 of the 14 patients had really dramatic PSA declines. And so this was a pretty exciting finding that we could use testosterone to treat cancer, which is very sort of counterintuitive to how we've approached it for the past several decades. The overall study was pretty encouraging too in terms of quality of life. Most patients actually felt a lot better, as you can imagine, getting testosterone treatment. Side effects were pretty well tolerated. There were a handful of patients that had serious side effects that were really related to the Etoposide. One patient developed a serious infection and died from it, and that was a chemotherapy-related side effect. Needless to say, that sort of really tempered our enthusiasm for using Etoposide going forward, and it wasn't entirely clear that it added enough benefit to really justify that. And so fast forward to today, we've started thinking about ways that we can sort of use this understanding of how testosterone works and come up with strategies where we can come up with a safe combination therapy that's better tolerated and hopefully more effective. And so what we're working on is combining testosterone with PARP inhibitors. PARP is a protein that's involved in DNA repair. And so if you imagine that testosterone induces DNA damage and you use a second drug that prevents the cancer cell from repairing that damage, it would make logical sense that the combination would work well together. And there's some data out of Pete Nelson's lab showing that this strategy does look effective. That's similar to the last figure I showed. When you use a PARP inhibitor with testosterone, you get more of the DNA damage in the cancer cells. And so we've designed a study that's going to open hopefully in the next month or two, looking at combining high doses of testosterone with a PARP inhibitor. The idea is these are men that have already become resistant to abiraterone or enzalutamide, and the cancer cells have essentially adapted to requiring this low androgen environment. And so by exposing them to testosterone, we hope that's going to be effective, and using the PARP inhibitor will hopefully allow it to work even better. So just in conclusion, most of the drugs we have out there right now to treat prostate cancer rely on inhibiting the androgen receptor signaling. Resistance occurs in almost every case. And I think combination strategies are really the way forward. There's already been some proof of concept with this from the 2 trials I mentioned earlier, looking at using abiraterone plus Lupron early or using chemo with Lupron early. And in general, the strategies that I've been working on, and along with my collaborators here, is looking at either this brute force method, combining multiple effective drugs, adding another drug to try to combat resistance, or sort of using our understanding of the biology to help us decide what drug would make the most sense to combine with the first drug to try to boost efficacy. And so that's all I got. Are we questions now or later?
After. Yeah. You can take a seat. So I'm sure you'll have questions for Dr. Schweizer. Make sure to write them down. We'll have the Q&A.